Okay. All right, Keegan, I will throw it over to you. Take her
All
away.
right. Thank you. Good morning, everyone, or good afternoon, I guess. I'm going to try to pop up my slides. Hopefully this goes well. Okay, are we seeing notes or are we seeing full? Okay, we're seeing presentation. Awesome, awesome. All right, well, good morning, everyone. I'm trying to be conscious of time. I know we have a lot to do in this 1 hour. My name is Keegan Abel Brown. I worked at Marshall University with the Center of Excellence for Recovery for the past about 4 or 5 years. And I've worked with Carolyn Canini and all the amazing work she's done for several years as well. I've had roles in behavioral health workforce development. I've had roles as an expert coordinator and in clinical settings working with juveniles that were justice involved or justice impacted. A large part of what we did with SBIRT, which is screening, brief intervention, referral to treatment, which was essentially a push to ask clinicians and providers about substance use with their patients in non-judgmental, just informative, educational ways, and to be able to have conversations that don't make people feel terrible about themselves, is recognizing that clinicians and providers themselves had a lot of stigma. And this was back in, kind of 2015 to 2019 kind of gap. And so, we were still facing substance use here in West Virginia as we are today, but there was a lot of stigma. There was a lot of really negative language out there, and so we put a lot of effort and work into reducing stigma. And a lot of our time spent training was spent teaching how you use these assessment tools, but it was just as much talking about how to kind of reduce stigma and why there's so much stigma related to substance use and mental health in the United States and abroad. And then most recently, I've been involved with the state stigma training revamp, which is Stigma Free West Virginia, because we still unfortunately see a lot of stigma, and we're still seeing, negative health outcomes associated with stigma, and fatal drug poisonings, folks not wanting to have naloxone and Narcan, things like that. So today's presentation, I'm kind of using some of the adapted materials from the stigma-free presentation. And so we're going to kind of just have a basic conversation on what stigma is and kind of where it comes from. And then we're also going to talk about some specifics for higher ed. Some of the things that we're going to talk about today are really going to focus on, or maybe hone in a little bit more on, those who are most disproportionately affected by stigma or don't have resources or kind of capital to combat how negatively stigma affects them. So kind of those in society who are disenfranchised. But any questions, please feel free to drop them in the chat. If you have a dying question, please feel free to just shout it out, and we'll get started. All right, so stigma, it's deeper than you think. I had to use a catchy title of some kind. Keegan Abel Brown. All right, so what is stigma? So I like this classic definition that we see: a mark of disgrace associated with particular circumstance, behavior, quality, or person. So this is kind of that historical definition we've seen. And so I just want to stop on associated with a particular circumstance, behavior, quality, or person. And so, for example, a stigmatized circumstance could be an individual experiencing poverty or living in poverty, and a stigmatized quality could be the color of your skin or sexual orientation, and a person could be the intersection. So an individual who experiences multiple, maybe they're engaging in certain behaviors or have multiple qualities, and we'll dive into that a little bit further. But stigma is complex. It's not just kind of this social awareness or this kind of negative social opinions we have about certain people or behaviors or conditions. It's also, it is negative attitudes and ideas, but it's also actions that we engage in, our policies, our systems that promote and reinforce stigma against individuals or entire groups of people based on, once again, that quality, condition, or behavior. And we're going to fully break that down. And so a simple way to think about stigma is the us and them mentality, that stigma creates a mental and physical barrier that separates people from individuals with stigmatized conditions, leading them to often self-isolate, see themselves as wholly to blame for their challenges, and really lead to worse outcomes. And so this is the part where I would usually ask for now what comes to your mind when you think of stigma. So if you don't mind either dropping in the chat, or if you want to do a quick unmute, just mentioning what comes to your mind when you think of stigma. I've kind of mentioned substance use. Is that the main thing? And today's conversation is couched in mental health. What comes to your mind when you think of stigma? Shame and suffering. Shame, yes, shame is a huge one. Yeah. So let's see. Or other, yeah, men in mental health. Yes, fantastic. Talking about populations. Yes. And we'll dig into that. Yes, homelessness, houselessness, community, judgment, closed-mindedness, people referring to other people as crazy, right? People using crazy, discrimination, yes, being treated unfairly. Oh, hey, Nate. Yep, media portrayals. Oh, that's great. Marginalized communities. Yes, love it. Okay, awesome. So yes, individuals, just like everyone's saying in the chat, individuals who are stigmatized or experience stigmatized are often devalued and subjected to discrimination or unjust treatment by our policies and systems. And it's socially and accepted. It's accepted as we accept it as professionals when we witness it. It's accepted by law enforcement. It's accepted by insurance. It's accepted by the media. And so it's not just, we recognize system or stigma is an issue and it's out there and all of us are fighting against it. Unfortunately, we take actions that support it due to unconscious bias and some other contributing factors, which we'll also get into. One thing we know through research, especially looking at substance use related treatment and mental health, is that stigma is one of the top barriers to accessing treatment and support. It stops people from even seeking treatment in the first place by negatively affecting the way that they see themselves and their condition and their behavior. It makes people think that they are totally to blame, that they're weak, that it's a moral failing for them not being able to change their behavior or to seek help. When really it is that intense level of shame that kind of we promote through multiple avenues. And so let me not stick too long on that slide. And so as we mentioned in the previous slide, stigma really does involve multiple factors. It's not just one concept against an individual or group. And so let me break down some of these factors. So the first one I want to talk about are the negative attitudes, and you probably have heard this as prejudice. Negative attitudes are usually our kind of emotional reactions and feelings towards people with stigmatized conditions. And so an example is kind of that historic moral outrage, such as anger, disgust, hate, blame, just like in shame people were talking about. Blame we see a lot is that we blame folks for their experience, and it's an attitude aimed at individuals with stigmatized conditions. So the second one we talk about are ideas and beliefs we have about people with stigmatized conditions. And so an idea or a belief about an entire group of folks would, you can call that a stereotype. And these are the generalized beliefs or thoughts about the characteristics and behavior of people with stigmatized condition. Everyone with anxiety or depression is like this, or everyone that uses substances are dangerous. And that's really the one I was going to actually share as the example, is that classic view that individuals who use substances or have a diagnosed mental health condition are dangerous and unpredictable. And that promotes stigma and kind of encourages us to start thinking that that person can't make decisions for themselves, that person needs to have someone make decisions for them, or maybe they need to have some kind of incarceration to ensure other folks are safe. And then lastly, the scary one, they're all scary, but this is when the kind of pedal hits the floor, is discrimination, is the actions we engage in that makes up stigma. And discrimination is unfair and unjust behavior directed at people with stigmatized conditions. So a couple examples are being passed on work opportunities or housing based on a disability or your racial identity. Examples of discriminatory policy are in the United States, there are different punitive policies that affect people of color, Black people, and communities of color, and they're more likely to be arrested for illegal drug use despite similar levels of drug use. And you can even look at historical examples of crack and cocaine sentencing minimums and guidelines. Some other examples of how we, promote stigma through our systems and policies are drug tests for employment and housing, but only if you look at it, most often is for certain levels of employment, there are drug tests involved. And then not in my backyard attitudes, NIMBYism, you might have heard, which is it reduces the availability of treatment. People don't want, or historically people haven't wanted substance use treatment programs in their community or harm reduction services, regardless of the fact that we know folks, would benefit from having those kind of support systems in their community. And that was one of the major reasons that West Virginia was so disproportionately affected, is that we didn't have programs that folks could engage with in their community. And thankfully now that has started to change, or it certainly has changed. And then you see at the bottom of this, kind of underlying all the things we just kind of discussed, is a lack of power, laws, and policy. And I think sometimes this gets left out of conversations related to stigma. We talk about kind of these general bubbles of how folks are discriminated against, that we have stereotypes and prejudice, but we don't talk about how, why that's allowed to be promoted and why it's so difficult to change and address stigma. Stigma often reinforces itself by creating unequal power dynamics in society. Individuals who experience stigma often do not have the power to change how others view them or their ability to directly influence the policies and laws that really are affecting them. And so why might someone who has a substance use disorder and maybe was incarcerated due to that not have the ability to change laws and policy? Well, they might have straight up lost their voting rights. They might have lost their voting rights due to being incarcerated. There have been targeted efforts in the United States, well documented, to reduce civic engagement of marginalized populations, whether that was, voting laws were passed where everyone could vote, but then Black people weren't allowed to go to the polls, or people were protecting at the polls with guns. And unfortunately, we even saw that in some previous elections. There's a lack of political power and historic political involvement. There's a lack of disclosure related to stigmatized conditions. Because these conditions or experiences or behaviors are so stigmatized, you cannot disclose that you are experiencing this. And so it cannot kind of reach that high level where we're really having a discussion about it and how our laws and policies influence it. There's often a lack of positive representation in media or the workplace. I can't even begin to start about stereotypes about individuals with substance use disorders or mental health in the media. I'm sure if you've seen any American television or movies, you've seen how kind of negative portrayals of mental health are, and the kind of one-sided portrayals they are. And so this lack of power, laws, and policy really does lead to disadvantages and negative social and health outcomes for those who experience stigma. So it's very challenging. We have these kind of long-seated beliefs and stereotypes and prejudice that kind of get mixed into the way our systems are built. And then the folks that are most affected do not have the financial power, the civic ability to engage with laws and policy. It's really difficult to change this. Even though stigma affects us all, stigma that is even directed at marginalized communities still negatively can affect us, even if we're not members of that marginalized community. All right. So a big thing we need to consider when we talk about stigma, or really anything in behavioral health, or really anything you do in your life, is recognizing that stigma is intersectional. And so what is the first thing that came to your mind when you even saw stigma as a presentation topic? Did you think I was going to come in here and talk about mental health or substance use? I know some folks put in the chat, but what stigmatized condition did you think we were going to come in here and talk about? If you don't mind talking in the chat, or you can say it out loud. Did you think it was substance use? Did you think it was mental health, or did you SUD, age? Yes, yeah. Mental health, okay. Substance use, mental health, right. Mental health, yep. Exactly. So for some people, it will be, they hear stigma and the assumption maybe because of, your role in your job or your experiences in life, it will be stigma related to substance use or mental health. Yet for others, they may have had experiences of stigma related to their racial identity, sexual orientation, or gender identity, and that's what they're first going to think about stigma. And so stigma is intersectional. This means as individuals interact with social systems or just systems in general, they may experience greater risk for negative outcomes based off the intersection of two or more stigmatized conditions or identities. So you see here on the left, we have health or behaviors. So mental health, you might have a mental health condition, you might have a substance use, HIV. HIV is one of the kind of most glaring examples of stigma and its negative outcomes. Weight-related stigma, and there's a great deal of research into how fat phobia leads to negative health outcomes for people who are larger that is not connected to their weight itself, and disability-related stigma. There is incredible amount of stigma related to disability. However, there's also stigma attached to all of these social identities have posted here on the right. And I think we often see that here in West Virginia, Appalachian identity, rural identity, even some aspects of our religious identity. These two intersections of, so if you have a substance use disorder and you're from a rural area and there is not very positive thoughts about mental health, or there's a bootstrap mentality, how do those intersect? If you're a Black man and you have a mental health condition, you might be, or you are, according to research, at a higher risk for being seen as violent and more likely to be incarcerated. If you are a woman and that you have a substance use disorder, it's harder often to engage in treatment programs due to often higher chances of being a single mother or having less opportunities in the community that are aimed for women. And so individuals might just experience a stigma related to one of their social identity, ageism, classism, racism, but often our social identity and stigmas and discrimination and stereotypes experienced on our social side and stigma related to our health behavior intersect and create really unique challenges, meaning that you and I can have different experiences when it's going to look different when we go to seek treatment, when we go to seek a provider. And that could be because of our income and access to payment or transportation, just a whole litany of things. That's a whole nother training on itself. And so implicit bias, this is a thing I am so heavily asking or encouraging or supporting. If you can engage in training, I know there's so much out there. I can share training opportunities if you're interested. My email's posted, but engaging in training and even reflecting on your curriculum, what you were taught, the evidence base that supports the modalities that you use as practitioners, or the outreach messaging you use, is recognizing where we have implicit bias. And we really have to spend a great deal of time understanding and addressing our implicit bias. And bias is simply our attitudes, behaviors, and actions that are prejudiced in favor of or against one group or compared to another. And so some examples are ableism, racism, classism, elitism, transphobia, fat phobia, homophobia, xenophobia, religious prejudice, really examining how in our practice that we could be committing microaggressions or not considering the other person's perspective or experience in the world and assuming our experience could be implied onto others. And I'm not implying that we are doing this on purpose, but every single one of us has implicit bias. It's not something that we can cure or totally train out of ourselves. It's something that we kind of continually have to work on if we really do aim to address stigma. And that is also another training in itself. And there are tons of trainings, as I'm sure you've seen out there. Another thing when we talk about stigma that I often see overlooked, and a lot more of the more recent research talks about, are the barriers to support treatment and recovery. And so when we talk about availability of providers in the community as a major barrier, that we just don't have providers or we just don't have capacity, how are we also thinking about barriers that are clients, patients, students face towards optimal mental health, but also their ability to engage in traditional mental health. So obviously, I have the big one with stigma. That's kind of an obvious barrier. But if people do not have kind of, I don't talk about Maslow so much anymore, but if people don't have basic needs met or they're facing real barriers, how can we expect them to kind of focus, quote unquote, focus on mental health? So if folks are struggling with stable housing, employment and financial resources, legal and criminal justice involvement, healthcare access and quality, education access and quality, so understanding mental health, nutrition and health, having access to food, healthy food, and then also if our services aren't culturally responsive and kind of embedded with structural racism, how do we expect for folks to successfully engage in our systems? So while some will experience or can experience negative consequences related to mental health or substance use disorders, others can experience greater challenges accessing support and treatment due to these socioeconomic factors, systemic inequity, and stigma. And so I'm just encouraging you as clinicians, as people who really do care about the populations you serve, start considering the material conditions that the folks you serve exist in, that their families, consider generational poverty, generational trauma, and the impact that has on the presenting behaviors that you're seeing. Because that really plays a heavy role into how people start to internalize how their success is, whether it's as a student, their role as a parent, as a son, as a guardian. They can start really negatively taking in these negative messages or internalizing those negative messages, and kind of forget that there's so much that they might be juggling with in their real life that takes priority. And so I just also wanted to mention real quick is that the materials that we are sharing or that I'm using today are part of the Stigma-Free West Virginia trainings that are coming out. And we're going to be training prevention coordinators and all throughout all of West Virginia to provide this training. And we're also looking for other behavioral health professionals who are interested in providing this training, or just other community members. So these slides will be available to you publicly at a future date if you would be interested in providing a presentation like this in your workplace or community. I just wanted to throw that out there. So let me quickly break down stigma. I'm going to walk through this relatively quickly because time is of the essence. But so what drives stigma? We've talked about stereotypes are huge, but policies and history plays a huge role. Thank you, Carolyn. She dropped the link for Stigma-Free West Virginia. But policy and history has a major role in stigma. And so if you're thinking about stigma related to a population or a behavior and issue, you have to start looking at the history of that issue or behavior in the United States. Why was HIV and AIDS so stigmatized? Well, what did it look like for LGBTQ community before HIV and AIDS in the United States? Why was the war on drugs? Why have outcomes been so bad since the war on drugs? Okay, well, what was going on? Why did we have a war on drugs? What else was taking place during this time? I'm not going to get into politics on here, but having a historic point of reference for understanding current stigmatized issues is incredibly important and will help you understand stigma that much better. Drivers of stigma, unequal power dynamics in society. We've talked about this. You cannot change the policies and laws if you do not have the power. Lack of education and awareness. When I was doing expert presentations and talking to medical doctors who had been practicing for years and fresh doctoral students just out of med school that were in their residency, they would tell me that they might have had one class that talked a little bit about substance use or how to address substance use. A lot of folks that go through behavioral health programs, and hopefully when you go through a graduate program, you would get some advanced training or at least a course on substance use, but there have not been that many great training opportunities about evidence-based practices to respond to substance use. Or trauma-informed care. That's a big thing that we've been talking about for the last 10 years or so, hopefully for the last 10 years or so, but it hasn't been the thing that's been embedded into what we do as behavioral health providers or people who work in this space. And so it takes a little bit it takes a little bit of time to start weaving an understanding of trauma and substance use and systemic challenges into how we practice in our systems and policies. And some of that is on us. And then, of course, fear of spreading disease is, when you look at the research, there is an adequate fear of spreading disease throughout human history. And so that we talk about with that with the HIV and AIDS. So these are, and then over here on the right, you see there are some clear examples of things that drive stigma: a belief that substance use disorders and addiction are a choice despite scientific evidence when you look at environmental factors, belief that people who use substances are dangerous and reckless, belief that substance use is a reflection of poor willpower or moral failure, and that people are to blame for their condition. And so all these kind of concepts really do drive stigma. Stigmatizing practices. How do we promote stigma, and how might we start reflecting on our own behavior? The language that we choose to use when we talk about individuals' behavior, or when we are creating documents, or we're teaching in the classroom, the language we use to talk about substance use. Are we calling it drug abuse? Are we calling people addicts? Or are we saying substance use disorders, drug use, substance use? So taking judgment and stigma out of our language, and that's why you hear stigma-free language. Negative media portrayals that we continuously do. I still see, when people talk about, they put out materials about mental health or substance use, you have pictures of drugs and needles and a pill spilled over with pills coming out, or you have like a really depressed girl looking down. It's really interesting how we use images to spread stigma. One example we would see I used to work in human trafficking, where images were really an issue. First of all, the media portrayals of human trafficking are all over the place and really inaccurate. And one really scary thing was, often the portrayals in the United States of human trafficking would show young white women in chains, like chained to a wall, or talking about the movie Taken. When you looked at the data and who was affected and what trafficking really looks like, it doesn't often look like a young person chained to a wall. Not saying it can't, but it kind of creates cognitive dissonance and spreads an inaccurate message. And so our negative media portrayals can spread really inaccurate messages. Thank you for the timing, heads up. Our discriminatory policies, like our criminal justice response to mental health or substance use. Our social norms and behaviors and beliefs around certain kinds of behaviors. Our stereotyping of individuals and groups, and then of course social avoidance and exclusion. And so this is a big one that I want to stop on, is that individuals will internalize messages of stigma. They will internalize that shame. I know I saw about 10 people write shame in the chat. People take that, they see themselves as not worthy of receiving help. They see it as an issue that they need to fix on their own. They are aware of the judgment from their community, peers, family. And so that really pushes them to socially avoid others, to exclude themselves, and to become more introverted, which we know often leads to worse health outcomes, unfortunately. What might it feel like to experience stigma? Well, you go to a doctor's office, and if you disclose substance use or a disability, or you have a weight that is not considered healthy, you might be treated differently. You might receive unfair treatment. They might not believe that you have the ability or right to make health decisions for yourself. They may make demeaning statements about yourself or your health behavior without recognizing the history that is you and you're experiencing, that you've experienced. You internalize those negative stereotypes and beliefs. You can anticipate stigma. So even when you're going to seek help, you know what people think about you. You know the thoughts about what people say when other people try to seek help for a mental health condition or disclose a mental health condition. And that's a really scary thing, and that could very easily shut you down from seeking help. Especially if you're on an insulated college campus, how quickly can that word get out that you are seeking support, or that you are seen on walking into your college campus's counseling center? And then there's secondary stigma. So say you have a son or a daughter or a family member who has a mental health condition, or even if you're a treatment provider in your community for certain conditions, there is stigma. They don't want you practicing in their community. People are talking about you in church, so there is these really negative feedback loops with stigma. And outcomes, just quickly going to run through this list. Decreased engagement in health and social services, poor quality of services received because of the lack of education and awareness, concealment of our condition, which, usually will just eat away at us, chronic stress, which, as trained in behavioral health, you should know will eat at your mental health, it'll eat at your physical health, and encourage you to engage in, maybe not so healthy coping mechanisms or responses, because that's what you have and that's what's accessible to you. That's the only thing you can engage with is maybe substance use or adrenaline raising activities. You cannot engage, you can't maybe go for a nice walk in the park or talk to a therapist on a weekly basis because you might not have access to those things. And then a higher risk of assault and injury, especially for those who are unsheltered or houseless or homeless due to stigma that's impacted them. All right. Stigma can be experienced in public arena. You can self-stigmatize. We see stigma in our structures, such as our policy and laws, and then courtesy and associative family members, us as providers or as people involved in this space. People can have these negative beliefs. So some quick ways to reduce stigma is to change our language, labels, and images, engage in allyship training, be aware of the language you're using, because the language we use as human beings dictates kind of how we think about things. And so be very conscious of your language, labels, and images when you're posting on social media. Think about a little bit about what I said about, negative image portrayals of substance use or mental health. Educate yourself and others, especially if you're working with marginalized populations, which if you think you aren't, you probably still are. They probably just aren't disclosing aspects of themselves to you. So there's tons of free training online, especially in the last few years. We've had, much grander social conversations about marginalized communities. Make contact and have personal experiences, attend campus events, attend peer recovery events, talk to people about the services you're providing to receive feedback, and then review your agencies or your center's practices and policies. And once again, ask feedback from the people you serve about, are there things that are making it harder to engage in our services? Are we promoting stigma? Is there language we're using that can be considered offensive? And ideally, hire these people into your program. Give them opportunities to provide some leadership or direction for you. Peer leadership is incredibly powerful and valuable, and who has a better understanding of that intersection of experiences and stigma than the people who it most directly affects. Do I have like 2 more minutes, or am I over my time?
Yeah, you've got about 3 to 4 minutes. You're okay. Yeah.
Okay, awesome. I know I'm going pretty fast. I just want to get to these slides. Let me see. So I wanted to talk about these challenges in higher ed, which this is really, some good stuff that we see is disclosure and what it means if you work in higher ed or I think a lot of us in here are clinicians that work on campuses, but if you are also faculty or staff on campuses, what does it mean to disclose a mental health condition or a substance use disorder, especially if you have to take time off of work, or if you have to like an extended period of time off of work, or you have to use some kind of medical leave, or that you are working on a research project and you have to disclose this? How does that impact your tenure and ability to receive promotions? And that's in any job field, right? Disclosing mental health or substance use can, in our beautiful capitalist society, disclosing these things can create real challenges in the workplace. And you don't want to lose your job because you don't want to lose your house and your ability to feed your family. But really in higher ed, where we're doing research or we're talking about these specific issues, what does it mean to kind of say, hey, I might have a closer relationship with this topic? Because on one hand, you would think this would be beneficial. I'm a person in academia, I'm researching, I value evidence, I value experiences. But also academia is a place often where there's some level of elitism, there's a level of control and some sticky power dynamics. And so this can be really difficult because we encourage people to disclose mental health or substance use. We encourage people to seek help, but how are we reflecting on our own experiences? Especially over these last few years, folks, like with COVID and the rise in substance use, I know y'all are dealing with some serious stuff. I know like it's hard to take care of our own mental health and really consider how hearing and reading about negative information and taking all these new trainings so we can better understand and serve our clients, but how are we taking care of ourselves? How are we processing this? And so maybe, yeah, take some self-care, love yourself, realizing you're doing the work too. Staff diversity is a big piece. So not just diversity of racial identity or gender identity, but also diversity of lived experiences, diversity of therapeutic modalities, being able to offer different services, diversity of cultural backgrounds. This can really open up services to a greater group on campus. Material challenges, and I think you're going to talk about that today, so I'm not going to get too much into that, but our actual capacity and how many people we can see per day and how often they need to be seen. And then campus policy and leadership, the things that we're trying to promote in mental health spaces or behavioral health spaces and be more positive. How does our campus policy sometimes come in and hit it with a hammer and say, well, we're actually trying to do the opposite of this. So looking at ways we can work with campus leadership and really get involved. And I'm sorry to ask you to do more in your job that you're already doing, but how can we get involved and kind of influence policy and leadership? Okay, and for students, what some challenges they have is obviously the biggest one that you're going to see come out in the research is that stigmatized experience of seeking support and requesting help. What does it mean to be a freshman living by yourself for the first time, 18-year-old, and having all these new thoughts and experiences, and maybe I have depression, maybe I have anxiety, and you go on social media and you see all this new information, you see people talking about it, and how you kind of weigh that against seeking help, versus seeking help in your community or your family. And so college students now are really having a lot more access to information about mental health, but still juggling with that stigma. And college university is not an insulated experience, and not saying it was ever historically, but now most students are working, they have family requirements, they have a greater social life or want a greater social life and want to have more diversity of experiences while in school. And so how is that playing into their mental health and their ability to kind of balance school, work, family life? Is there so many competing deadlines and things that they're trying to accomplish that it's negatively eating at their mental health, but they're internalizing it and seeing it as, I'm not strong enough, I'm experiencing this level of depression, you know I need to work harder. We can really start internalizing all these pressures. Accommodation stigma, and this one is, how can we start looking at how students who might have a disability, or if you go by the social model of disability, who need accommodations or require accommodations, how are they stigmatized when other students might see them receiving an accommodation? Are we putting out information publicly about why accommodations are available, that you should seek support or help if you require accommodations? Are we talking to the folks that we serve about accommodations that are available through our university's compliance office, where they can get some assistance? And then also kind of wrestling with those difficult professors sometimes, where accommodations aren't always respected. And then on a greater scheme, that we have people, or intellectualism in the United States is kind of slowly being bitten at over the last 10 years, unfortunately. And the value of degree it's shifting. It doesn't have that same historic guarantee, and the American dream doesn't have that same kind of historic guarantee, especially as college campuses are opening to more diverse sets of students, and the workforce is becoming more diverse. People are recognizing that
Keegan, I think you froze on
salaries that are
us.
available upon graduation. Okay, awesome. So basically, just students are reckoning with this kind of balancing of the reality, essentially, that they're in college, they're working really hard, but is this going to lead to a really grand outcome? And that can really lead to some really challenging mental health. And so I'm going to stop there. I'm going to put this slide up there. And if you have any questions about what you can do to reduce stigma, there's a ton of material out there. I'm happy to share any of my material. But that is my 30-minute presentation on stigma. Thank you, folks.
Keegan, thanks so much. I know it's hard to get through all that information. You did great. The slides will be available, the recording will be available, and thank you for putting your email on it as well. So I appreciate that. Any questions before we switch gears? Head shakes no. Okay. Well, if there are, anything that comes up, please put it in the chat. We'll make sure to be monitoring that. But in the meantime, we'll switch gears and we'll go to the case from Wendy, Jamie, and Kelly. I will pull it up and share the screen and just walk us through it real quick, and then we'll open it up. Just give me 1 second. Okay. So whoever's going to lead, if it's Wendy or Jamie, unmute and feel free to take it away.
Thank you, Keegan. That was a really excellent presentation with lots of information that segues really well into what we want to talk about today. So we're on a journey to revamp our services and be more out there with outreach and support groups, and to really normalize mental health challenges, to let our college student population know that we're here, that we're approachable, that we want to serve them. And we have a lot of strengths that we're working from, but we also have areas that have been a challenge for us. So we would like to take this opportunity to crowdsource some what's working for those of you out there who may be already doing the things that we're working on revamping, or who have some good ideas that could just help us in moving along. So each of us are going to take a question and pose it to the group. And so Kelly, I'll turn it over to you for the first question.
Thank you. So we'd love to get feedback from you all about how to increase group participation and increase participation of both non-traditional and traditional age students.
Feel free to unmute or put your responses in the chat. Thank you, Jamie. You just beat me to the punch.
I have just one thought that I've seen with collegiate recovery and having kind of individuals who are in recovery lead peer spaces on campuses. And it's really nice where they offer, food and a safe place to be. If you're on campus for a day, you can go kind of hang out in a lounge. And I know that requires some grant funding, but having kind of peer spaces, whether that is related to substance use, individuals in recovery, or mental health peer spaces, and allowing the peers to lead those spaces, or to have a lot of power in those spaces too.
Thank you very much.
So what I was also hearing, Keegan, is being able to have a space for almost like fellowship that can be kind of just a space that we're holding to invite the fellowship and the support. Okay.
Yeah, I think I know several campuses. I know we have some space at Marshall, WVU. There's some other campuses where they have a physical center on campus where there's couches, there's food, there's games, you can play Uno, but it's just having kind of that safe space. And they serve traditional, especially for the recovery community, and non-traditional age students as well.
I'm from Pierpont Community Technical College. I was responding to Caroline's post on the chat, and we have a huge problem with getting any students to come to anything outside of their classes, traditional and non-traditional students. So support groups right now are just in limbo for us.
I was just going to say, here at West Liberty, we have a creative arts therapy program, and we also have a creative arts therapy club where a lot of those majors, they get together twice a month and do more just art making for more like stress management or just relaxation, something where they're not doing papers, but it's art. So they're having fun coming in. And at the beginning of this year, it's a student-led organization, but the officers, they wanted to have like a beginning of the year program for students and invite the whole campus. And it was creating calming jars. And so it was one of our biggest events. We had about 50 students come to that event to create a calming jar. And I have an example here. It's just a plastic jar with glitter in it. And students loved it. But what I noticed of just kind of observing was students came in, and one student said, I have, a panic disorder, or I struggle with stress management. So when I heard that this was going on, I had to come and make one. And so for me, and in that moment too, that student was supported by peers, kind of normalizing, having difficulty managing stress. So for me, I was able to see just not only they have a tool now, but also coming and creating it, they got support they needed from one another. So maybe even offering just like non-traditional therapy type events that are focused and kind of talk about mental health. We advertise it as come and make a calming jar. This will help, to help manage school stress. It's the beginning of the year. And this, something you can create that will help you throughout the semester. So we kind of brought up the idea that it's hard. It can be really hard to manage things, and that's okay. And here's how we can support one another in that.
Great comments, Terry. Great comments in the chat from Keegan about have the students plan the event. They know what will get them there. That's a great point.
This is such good feedback. I knew that we were on the right track asking you all to share your wisdom. Thank you so very much. If there's other input about groups, please feel free to jump in the chat, but in the interest of time, we'll just jump to the next question, which is, do you all at your college mental health center have any policies regarding session limits? And the reason we're exploring this is that, we have found that more and more students are reaching out for individual support. We're working on, developing these support groups, and that's helping us to both meet the need and harness the energy of the staffing that we have. But it's very easy to get overwhelming caseloads. And with the greater level of needs that we're, observing in our student body, we're wondering, if, because we're short-term solution focused, if we should be putting a cap on some sessions, of course, with some clinical judgment in there for times where we have to make exceptions.
Wendy, this is such a great question. And I was on a call a couple of weeks ago and heard another campus from another state talking about this. And they were talking about it from an advocacy perspective, saying they went to their administration and said, the funding that we currently have allocated for counseling services pays for this much. So here's how much one counselor or two counselors can accomplish and how many sessions we are currently paying for, as a way to say, we can try to handle the increase as the semester goes on, or as acuity increases, year to year in the student population, but this is how much we're currently paying for, and limiting it that way, rather than creating a structure that is constantly in a state of flux based on the needs. Of course, you all know you also have to do that but being able to say, here's what we have the resources for. Is this what we want to do as an institution? I thought was an interesting way to address that question.
Thank you.
So I'll ask my question. So given, I think a lot of us can relate to on campus, noticing a lot of, boundaries associated with high volumes of students that are coming to us, we were interested in knowing how are college mental health centers increasing crisis response supports for acute mental health needs during and after hours?
Jamie, and Wendy, just a comment about question 2. We are not a medical provider, deal with this kind of stuff, but we often frame the ask like Carolyn said about, here's what we do with the funding we have. Just think about what we could offer if we just had X more, right? If you go make that ask. So like you show your capacity, you show your ability to work not only within the funding and outside the funding, but just, you're not asking for $1 million, although that would be awesome. You're just asking for that little bit more to show like it doesn't take much and we can do, that. So I think that's a great way of kind of dealing with the capacity issue, because we do the same thing in our realm, those kind of asks.
Another part of the question, like some of the things that we've been trying to do to fill the gap of just our crisis response is, being able to have trainings with our RAs with how to manage crisis. Also being able, every time in our emails, we have hotlines for responses. We review during our informed consent what students to do, what they need to do if they are in a crisis situation, but we were just curious if there was any other suggestions of what to do. So.
And if I could just piggyback onto what Jamie's saying, is there anyone here who works at an institution that has like a memorandum of understanding with either a local crisis response team or hospital behavioral health unit? Those are things that we've also kind of been curious about, and just wondering if we might make a connection with anyone who's gone through that process that would be willing to consult with us. And if not, maybe we can join together and pioneer together. If there's anyone interested in talking to us about, making their own plans for this. Carolyn, then maybe we should reach out to Marshall's Counseling Center based on your chat. Okay, Candace Lane. Awesome.
And I just wanted to throw out that this, because of the new 988 rollout and the, the new the law and requiring that, there's a huge amount of like kind of statewide capacity building going on, hiring and training for those crisis response teams. But I'm assuming don't expect anything until kind of mid 2023. And then even at that point, how it is. So yeah.
Keegan, that just made me think about 988. I think would be a good topic of discussion for ECHO maybe in the spring as things develop more with the services that are available and how colleges can really promote and leverage the resources available through 988. So if anybody's interested in that, let us know when you fill out your evaluation, and we'll look at having that as a discussion in the spring.
Wendy, Jamie, Kelly, anything else? We've got about 4 minutes. Anything else? A lot of good stuff in the chat. We'll make sure it's in the recap to you guys, and all the links and everything like that. But anything else?
I would just like to reiterate that, Keegan, when you talk about harnessing peer support, that's something that we are seeing more and more students even coming to us and saying, we want to partner with you. And we have a student that is developing a club and has gone all the way through the process and is having the first meeting shortly, and it's called Rams Care. And that's so exciting for us to have a group of students that's going to grow and be interested in student-led mental health initiatives and partnering with us, and also the social work program. And we are starting an all recovery group this week, which is super exciting. And it's something that, we feel is going to grow pretty quickly, given, the level of interest that we've, just heard murmurs about so far. And the emphasis on that will be, that it's something that we want our students to have, a leadership role in. And there's also other students that are wanting to develop groups, like one for chronic health issues. And so it's just super cool to have this opportunity and to hear, these echoes of what's going on. It's validating that we're in good company.
Well, thank you, all three of you, for presenting the discussion topic. That was a great example of what we're looking for as far as, the second half of the sessions where we're not doing the didactic. It can, that crowdsourcing, that's a great way of putting it, getting some feedback on some ideas and things like that. So please keep those kind of things coming for the sessions. That's what really makes it great. Hopefully makes it, beneficial for everybody. I'm going to go ahead and put the survey, the evaluation link for this session. So again, be sure to fill that out. Again, if you can't fill it out right now, it'll be in the recap email that'll come out later today, early tomorrow. So you'll have another chance, but we really appreciate the feedback. And especially if you are interested in the spring, any spring topics, please, it's a place to put them in there. All right, next session will be on November 1st. So be on the lookout for the reminders of that. If there's anything in the meantime, please don't be shy. Be sure to email us, and we will see you in a month. All right, everybody take care.
Thank you.